Hi, my name is Rami Doukky from the American Society of Nuclear Cardiology. I'm the Chief of Cardiology at the Cook County Health and Hospital System and a Professor of Medicine and Radiology at Rush Medical College. And with me is Dr. David Winchester, who's an Associate Professor of Medicine and the Program Director of the Advanced Fellowship in Cardiovascular Imaging at the University of Florida in Gainesville. Dr. Winchester is a renowned researcher in the field of appropriate use of medical imaging. Dr. Winchester, thanks for being with us today.
Hey, absolutely. It's good to be here and talk about this.
Dr. Winchester, we have a controversial topic to talk about this morning, I want you to touch on what are the appropriate use criteria, or so-called AUC, and how are they developed?
Sure. So appropriate use criteria are promulgated by professional societies or other entities, and these are something similar to guidelines, but they tend to be a little bit more clinically oriented, something that somebody can use more readily at the bedside to try and guide their decision making about when a medical procedure or a service or a test would be appropriate for a given patient in a given clinical scenario, and also to provide some guidance about when tests and procedures would not be as appropriate and not be helpful for patient management. Within cardiology, there are a lot of different appropriate use criteria. Professional societies in cardiology have been developing these for the last several years, and so there are appropriate use criteria for coronary revascularization, for valvular heart disease, for congenital heart disease, but specifically we're going to be talking more today about the appropriate use criteria that relate to non-invasive imaging, and specifically focused on the ones for nuclear imaging, for cardiac CT, and for cardiac MRI.
Fantastic. Can you tell us a little bit more about how these appropriate use criteria are developed?
Sure. So at least within the College of Cardiology, which has been one of the leaders in this area, the way the process works is that there is a task force that's responsible for sort of surveying the landscape of cardiology and looking for areas that might benefit from having some additional guidance in this particular format of appropriate use criteria. That task force will identify these areas, and they will convene a writing group that's going to be a group of clinicians in charge of developing the criteria sort of from start to finish, and then writing the document that summarizes what they think about this particular group of tests or procedures. That writing group will be a very representative group. It usually encompasses people from a variety of medical societies, a variety of backgrounds, invasive, non-invasive, people with statistical backgrounds, people with clinical trial backgrounds, people that are researchers, people that are on the front lines providing care. That group is going to sit down and say, here's our topic. Let's say it's we're going to cover cardiac CT. So what are all the reasons or potential ways that somebody might want to use a cardiac CT? And so they're going to write up a bunch of different clinical scenarios that encompass a broad swath of clinical practice. They're going to do a literature review of everything that relates to that test, that modality, whatever it is, and those clinical scenarios, and see what's out there to guide the appropriateness of a given test. Those clinical scenarios in that literature review is then going to go to a separate independent panel of people called a rating panel. And they are going to say, okay, well, for clinical scenario 1, for this sort of patient situation here, is it appropriate, maybe appropriate, or rarely appropriate to do this test? And so they're going to go through and do a whole bunch of ratings to make assessments of this. And it's also a broadly representative group. Each person is going to cast votes, sometimes in 2, 3, however many rounds of voting they need in order to get to some degree of consensus as best they can. And then those ratings are going to be sent back to the writing group for them to build into a document that can be published. And then that document will go out. It will get published in all of the major journals related to the societies that have participated. And then we will go back around that cycle, just like guidelines get renewed and other clinical practice documents get renewed. We'll go back and we'll take a look at those appropriate use criteria and say, okay, well, it's been a while since we looked at these. We need to review the landscape again and see what's going on with this cardiovascular test.
This is very, very helpful overview. So we want to stress here that the way appropriate use criteria are developed is basically based on rounds of voting, and this voting obviously is guided by guidelines and research, but it is again it is a sort of a consensus or semi-consensus between experts and practitioners, which is an important distinction from clinical practice guidelines.
Yeah, I think that's really an important point to make. These are sort of an extension from clinical practice guidelines more into, gray areas of medicine. And they are informed by evidence to the best that they can, but, not everything has got 5 randomized controlled trials behind it. And so sometimes, what we have to rely on is expert opinion or consensus of expert opinion. And that's what these are really trying to try and boil down for the average clinician who maybe doesn't have access to 5 different experts on a given test modality for a specific clinical situation.
This is a very important point to highlight indeed. Now, appropriate use criteria have penetrated our practice for the past decade or so, and clinicians across the spectrum have been becoming more aware of appropriate use criteria. But there have been, in the past few years, there have been a little bit of a shift. Now, it seems like there have been a mandate from the federal government that's going to be implemented by Centers of Medicare and Medicaid, CMS, which basically extend the use of appropriate use criteria into CMS coverage of certain testing, or so-called the PAMA law. Can you please explain this law and how it's going to impact our practice?
Yeah, so the appropriate use criteria, like you mentioned, they've been implemented in a variety of different ways. Some folks have put them into their practice or their academic center or their large health systems have adopted them. In some instances, some third-party payers have used them for decisions about reimbursement. But what happened in 2014 was that Congress took note of this, and in one of the laws updating Medicare and reimbursement from Medicare, there was a provision included where the Secretary of HHS, of Health and Human Services, was directed to adopt appropriate use criteria for imaging services from professional medical societies and other provider-led entities. And like you said, basically Congress told Medicare that in order to reimburse people for doing what they refer to as advanced imaging tests, that providers would be required to use appropriate use criteria in some fashion within the ordering process. In a typical way that Congress approaches these things, they sort of gave CMS a directive, but they didn't tell them exactly how to do it, and they left CMS to decide how to best achieve the goal that was set out for them. And so what they've sort of outlined at this point is a process where the expectation is that the person who's ordering a test, and I should specify that, when I refer to advanced imaging tests, this mandate only applies to nuclear and PET, so for us, SPECT and PET, for cardiac CT and for cardiac MRI. Cardiac echo was not part of this mandate, and that's something we can talk about a little bit more later. But if you're ordering any of those other tests, nuclear, CT, or MR, the expectation is that whoever is ordering the test is going to have to consult with some appropriate use criteria at the time they're seeing a patient and ordering the test. And when that order is generated, it is going to need to be accompanied by some evidence that the AUC were consulted, including what the determination of that AUC lookup was it appropriate or not, and also which AUC did you use. We'll talk a little bit more later about the fact that there's not just one AUC. So that order gets generated, the test gets performed, the report is completed. Now you're the physician that's been doing the test, and you're going to submit your paperwork for reimbursement. And so you need to have that evidence of the AUC determination when you submit that reimbursement. And initially, the idea is that Medicare is just going to watch and just going to gather data. They're going to see who's ordering what, how much low-value, rarely appropriate tests are being ordered, and they do have some specific priority areas they're going to focus on. But then after a few years of watching, they're going to start identifying the outliers. And so the people that are using more rarely appropriate testing than others are right now what they're projecting is that those people will be subjected to prior authorization. But once they have this data, Medicare could conceivably do any of a number of things with regards to reimbursement, the process of reimbursement, withholding reimbursement, so on and so forth.
It sounds quite cumbersome.
Yeah, and that's one of the challenges we're going to talk about is, on the surface, the idea that somebody has to consult AUC when they order a test, it may not be that easy. It's the documentation and the proof of it that's proving to be a bit challenging.
Do you see problems with implementing PAMA, or just to spell it out, it's Preserving Access to Medicare Act?
Why don't I talk a little bit first about, there are a couple of other things that are required within PAMA that are relevant. They're a little bit in the weeds, but, I think we can quickly go through them. They don't want just any group of people saying, here are some appropriate use criteria, stamping them, and then being able to use those to justify any test, right? So you could, imagine that a couple of people just sit down and say, well, here's 30 reasons why I want to order a nuke, and they're all appropriate, so yay for me. So they've actually got some very specific requirements. Any AUC that get developed have to be accompanied by a systematic review of the literature that has a formal grading of evidence, references to relevant guidelines. They have to be developed by a multidisciplinary team that includes a clinical trials expert, a statistician, primary care, specialists, and imagers. They have to have public, transparent declaration of any potential conflicts of interest. And the criteria have to be published so that they can be reviewed by anybody who's interested in seeing them. The AUC also are only going to be acceptable if they are developed by a provider-led entity. And so, as much as we all love the term provider, it's enshrined here again in one of these things. And so, what they mean by that is a national professional medical specialty society or other organization made up primarily of providers. So that is, a Society of Nuclear Cardiology, College of Cardiology, but it could also be a hospital or a health system where the work is primarily done by providers, and specifically providers that are giving direct patient care. So you've got these requirements about how they have to be developed. You've got requirements about who can actually develop them. And then you've got a number of organizations then that have qualified, the ones that we've already mentioned, the professional societies. but there are currently 20 approved provider-led entities that also include Cedars-Sinai, UPenn, the MGH Department of Radiology, and a couple of organizations that are not societies or facilities, like the High Value Practice Academic Alliance and the CDI Quality Institute. The first of those being an academic collaborative built out of Johns Hopkins, and the second is this interesting amalgam. It's an organization that is a provider of radiology services, a physician management company, a mobile imaging provider, and they also offer healthcare consulting services. The other wrinkle in it that we want to just touch on briefly is that the requirement for reporting these things is actually, the other layer built onto it is that you have to use an electronic tool for determining your AUC. And so the way this has been written up is that you have to use a clinical decision support tool, something that would be built into your EMR, your EHR, and basically when you're the ordering doc, you go to the menu for nuclear cardiology, and then that says, well, here are the potential indications, and here's the appropriateness for it, or what have you. So this is now another layer of complexity, where not only do you have to consult these things and document that you're consulting these things, but you have to do it through these specific electronic systems, which, like the provider-led entities and like the development of AUC, also have got very specific requirements about how they can be developed, who can develop them, so on and so forth. And, like with the provider-led entities, there are a number of these that have been approved already, and Medicare did mandate that a couple of them at least had to be free. So, if you're out in practice, solo or in a small group, and, the cost of complying with this, could be substantial, but there are some free options out there, which hopefully are going to minimize the burden for people.
Sounds quite involved. Do you see problems, or do you anticipate problems with implementing PAMA or preserving access to Medicare Act?
Yeah, so the implementation has been a real challenge for Medicare and for the professional societies that are trying to help Medicare do this in a way that is, complying with the congressional mandate, but also not being overly burdensome on either the physicians that are ordering these things or the physicians that are performing and interpreting these tests. And, this law got passed in 2014, and the original deadline for implementation was actually 2017. And, take a look at your calendar, you'll realize we've passed that and this hasn't happened yet, because there's already been one delay to 2018, and then currently implementation has been delayed until 2020 because of some of the problems that have come up. And, some of the things that are challenging here is, I'm at one practice, you're at another practice. Does my EMR talk to your EMR? If you're going to be doing a nuclear study for me, how do we get all those EMRs, to talk to each other? And if not, what do I have to resort to? Does my EMR have to generate something on paper that I have to fax over to your office to prove that I consulted the AUC? These are, like we said before, conceptually simple things, but in practice and implementation, they're much more challenging than you might think initially. One of the other issues that come up is that there are, like we said, a whole bunch of different entities that are approved to develop appropriate use criteria. And so what happens if there are conflicting appropriate use criteria? What happens if one set for a given patient scenario says that one's appropriate and the other says it's not appropriate? And for that matter, if you are the provider that's ordering the test, how do you know which one to consult? Does your EMR have to include all of them? What if ordering a nuclear study for somebody with chest pain, what if there are 8 different professional societies that have provided an AUC recommendation for that? Do you have to look at all of them? So it gets really complicated really quickly.
I can see scenarios where it might actually promote additional testing or additional utilization of services, such as if I'm a primary care physician, I don't want to really deal with all these appropriate use criteria. Maybe I'm going to consult a cardiologist next time, or I'm going to consult a specialist to figure out whether it's appropriate or not, rather than figuring it out myself using appropriate use criteria tool. I can see scenarios where perhaps societies would figure if they're going to be regulated on the basis of utilizing appropriate use, maybe we stop developing new appropriate use criteria. So there can, possibly there could be, the laws of unintended consequences kick in here and might complicate things a little further.
Yeah, no, I totally agree with you. And, these are just sort of the very easy to identify surface problems with implementing this, but you could certainly imagine all sorts of other unintended consequences of this, and driving more patients for cardiology consultation for, simple, straightforward things that otherwise probably don't need that level of expertise, but, can't figure out how to order the test, so I'm just going to let somebody else take care of it.
I'm also familiar with some of your work demonstrating that appropriate use criteria are not necessarily created equal and can lead to different determination for the same type of scenario. Can you shed light on some of that?
Yeah, absolutely. So we did some work a couple of years ago and published it in JAMA Cardiology, basically just trying to look at, just as an example, sort of a pilot here, we said, what is the potential implication of the fact that there are multiple appropriate use criteria, for example, for nuclear cardiology studies? And so we had some data from a cohort of about 600 patients that we had already done rating of appropriateness by the College of Cardiology criteria, and we went back and we rated them all by the College of Radiology criteria. And I should mention, radiology has been doing appropriate use criteria for a very long time. They've been doing it longer than cardiology has. But they've got, they are, imaging is what they do. So they've got a lot of appropriate use criteria related to all sorts of imaging. So we took their recommendations about nuclear cardiology, compared them to the College of Cardiology, and ended up finding some really, striking and concerning sorts of things. The first, if we were to look at it on a sort of the most macro level, and we just said, this clinical indication, this clinical scenario here, can we find the closest analog in the other set of criteria, and then between those, does the rating of appropriateness agree? And for starters, we found that roughly half of the indications that cardiology had no analog in radiology.
Wow.
So there are a whole bunch of things, and just as an example, somebody who's got non-sustained VTAC. As a cardiologist, I might be interested in ordering a nuclear study for somebody like that. But there was no analog for that within the College of Radiology. Their criteria are, they're just built differently. So there are a whole bunch that just had no match whatsoever. Of the ones that did have, an analog, the majority agreed on appropriateness, but again, almost half, a little less than half, actually disagreed on whether or not the test was appropriate. Now, there are three categories here. There's appropriate, maybe appropriate, and rarely appropriate. And so, thankfully, most of these were only one category apart. They were either one was appropriate and one was maybe appropriate. But there were a couple where one set of criteria said the test was appropriate and the other said it was rarely appropriate.
Wow.
And so, that's concerning, on a high level. If we drill down to the patient level, it gets a little bit better. Some of the ones in cardiology are relatively infrequently used, so the number that didn't match on a patient level was lower. It was only, 10, 15%, something like that. When we looked at the ones where there was an analog, it was about 80% that agreed. But again, there are about 20% of patients where it was rated one thing by one set of criteria and rated something else by another set of criteria. extending that into outcomes, we looked at within the cardiology criteria and the radiology criteria. We took a little backwards look at this. We said, what if you had ischemia on your nuclear study? How often was that rated as not appropriate? Because there's a whole bunch of other data within the cardiology literature that if you have a study that's not appropriate, it's rare to find ischemia. But that wasn't the case with the radiology criteria. Within those that had ischemia, 17% were actually rated as usually not appropriate. And amongst all the group that had an abnormal nuke, 35% were usually not appropriate. So there's a substantial amount of abnormal test results that were being done on patients that would have been rated by radiology as not appropriate studies. So this really brings up some concerns. Like we said before, which of these criteria do you use? Now, what do you do with this kind of data? What if you want to order a nuke on somebody and one set of criteria says it's okay and the other set says it's not? And what sort of guidance should you take from this? This is a real challenge. For what it's worth, professional societies are trying to harmonize this, and they're trying to come up with some ideas on how to minimize these problems. There was a summit that got put together late last year that was actually moderated by CMS. The College of Cardiology hosted it, and they brought in decision support vendors and provider entities and primary care organizations, imagers, and sought to, at least identify, what are the areas where we need to be working on this. So, the leadership of these organizations is aware, and they're trying to help CMS make it work. But it's going to be a serious challenge. There are a lot of issues with this mandate for sure.
Yeah, the fact that it has been delayed so many times really speaks volume on how complicated this is. I mean, it has been delayed several years already, and I hear that even we're not so sure whether CMS will be able to implement it even in 2020. So this is certainly speaks volume of how complicated this matter is.
Yeah, absolutely. And I think it's just sort of a final point to, on a health policy perspective on this. That, like I said, we've all the professional societies have been engaged with trying to give CMS feedback. One of the other bits that sort of changed the landscape that came along after PAMA became law was MACRA. And I think folks are more familiar with MACRA because its implementation is moving forward a little bit more steadily than the PAMA mandate is. But MACRA is built so much around quality of care, that people have sort of raised the question, well, couldn't we figure out a way of making, this PAMA mandate something that fits within the bigger picture of MACRA? Is this something that, for the facilities that are able to figure this out and do it easily, if you're in an accountable care organization and everybody's using the same EMR and, you can get everybody on the same page in terms of which criteria to use, maybe there are certain pockets that could implement this easily. Maybe those facilities could get credit for quality of care payment adjustments under MACRA.
Where do you see the research going in the near future as it relates to appropriate use and its implementation? What do you think where should we be looking?
I think that appropriate use criteria have been around long enough that we've done a pretty decent job of documenting the scope of the problem in terms of, basically now we have a vocabulary for trying to be able to at least some degree reproduce and say this is how much low-value care is going on out there. We've got a set of definitions for what is low-value care. And so I think that literature is pretty mature at this point. I think where we need to be going is we do need to be looking more at implementation. We need to be encouraging facilities to adopt these within clinical practice somehow, and then write up their results and talk about what was good, what was not so good, how can we improve, what can we, how can we make these better. So I really think that the literature needs to be focused more on implementation at this point.
Yeah, I agree with you. We really need to know how this will impact our daily practice in the environment of health systems, complicated health systems, and what are the potential costs of implementing it, because it is, as we touched on earlier, there are going to be unintended consequences of implementing the appropriate use criteria. So this has been very enlightening discussion, Dr. Winchester. I really appreciate taking the time to talking with us this morning.
Yeah, it's been my pleasure.
All right. Thank you very much.
Thank you.